Hi everyone, welcome to Unit 1, Lesson 2. This is all about heart conduction. So in our very first lesson of Unit 1, Lesson 1, we had a nice review about the different parts of the heart, their function. We learned a little bit about heart rate, how to determine that on an EKG, kind of what our little boxes mean and everything. So this, we're going to expand on that and we're going to get into heart conduction. All right, so let me go ahead and get right to it. So today we're going to first review. We're going to talk about A rate versus V rate, which is atrial rate versus ventricular rate, different EKG intervals that are normal and what will be abnormal, what might cause those, some lead sticker placement, your lead direction, and heart access. There will be some points where you can stop and take a break. Please do that, pause when you need to, and if you ever need to review what I just said again, just rewind it. The good thing about videos, you can just rewind and start over or start in that section over again. All right, so let's review. First question. On your paper, you're going to follow along on your note sheet. It says question 1, what is happening when the Purkinje fibers fire? So take a few seconds and write that down. What is happening when the Purkinje fibers fire? Question 2. What is the formula for Einthoven's triangle? So we had this little formula made up with our different leads, and it was to let us know if the lead wires were hooked up correctly. So what is the formula for Einthoven's triangle? That's number 2. Question number 3. What represents the SA node on an EKG? The SA node. Sinoatrial node on an EKG, what does it represent? One little blip on there represents the SA node firing. Let's get into question 4. What is the correct order of numbers to remember when determining the heart rate using the countdown method? And there's some numbers you had to memorize in your head. Started with a certain number and went down in increments. It's how we got the 1500 method, but it's just a way to remember it without having to do all the math, right? Okay. Go ahead and write those down for question 4. If I'm going too fast, just pause and come back. I'll give you all the answers when we're done. Question 5. What represents ventricular depolarization on an EKG? So when those ventricles depolarize, what is happening on the EKG? Like what waveform is created? And question number 6, our last question. How fast does the backup pacemaker beat? So we had a pacemaker, we had a backup, we had a backup to the backup. We want that backup one, the one in the middle. How fast does that backup pacemaker beat per minute? Okay, excellent. Hopefully you have them all written down. Let's go through the answers real quick. Make sure you have them right. So self-check here. What is happening when the Purkinje fibers fire? So the Purkinje fibers came down at the bottom of the septum, and at the apex they branched out and became Purkinje fibers. And when they are engaged or firing, they are squeezing the ventricles, both the right and the left. So that's one thing that you could have written down. So Purkinje fibers are squeezing the ventricles, making them pump, squeeze, push the blood. Question number 2, what is the formula for Einthoven's triangle? That was 1 plus 3 equals 2. So remember the size of the QRS in lead 1 plus the size of the QRS in lead 3 should equal the size of the QRS in lead 2 because we have our right triangle, and that is the formula for a right triangle. 1 plus 3 should equal 2. And if it doesn't equal, we go back and recheck our leads and make sure that they are on the right arms and legs and all the right spots. Sometimes it doesn't add up and it's just that person's normal because their EKG their normal is abnormal. It doesn't happen very often, but it should prompt you to go back and double check. Question 3, what represents the SA node on an EKG? Real simple. The SA node's firing. That's the very first thing that happens in the heart conduction. So the SA node will be the P wave on the EKG, the very first bump. We start with the SA node, therefore we start with the P wave. Okay, question 4. What is the correct order of numbers to remember when determining the heart rate using the countdown method? So remember, this is actually the 1500 method that you just memorize in your brain. So we start with 300. So that means if the QRS is on this line and the next QRS is on the next line over, it would be beating at 300 beats per minute. That's fast. So it goes 300, 150, 100, 75, 60, 50. And then after that, it goes down in increments below that 40. You just have to, at that point, it's they're not all even numbers, so it gets a little messy. You have to do the math. But it's obviously Brady at that point. So question 5, what represents the ventricular depolarization on an EKG? So when something depolarizes, it is contracting or squeezing. So when our ventricles are squeezing or contracting or pumping, pushing blood, it's creating that big, large spike in the middle of that QRS. So the QRS complex represents ventricular depolarization. Repolarization, if you remember, is when the muscle relaxes and repolarizes. Those ions swap back to their original place. How fast does the backup pacemaker beat? So remember, we have the SA node as our pacemaker. It beats 60 to 100 beats per minute. Our backup is our AV node. And since it's on a little bit of a delay, it beats at 40 to 60 beats per minute. So the answer to question 6 is 40 to 60 beats per minute. Now, if that one fails, we have the second backup, our bundle of His, if you remember that one. That one beats at 20 to 40 beats per minute. So enough to keep us alive and sustained, not really like perfect for doing everyday things and surviving thriving. It will keep you sustained at least until you can get medical help. Okay, let's get on to the lesson. All right, so A rate versus V rate. So V rate, when we talk about the heart rate, we're talking about ventricular rate. Okay, so it's how fast the ventricles squeeze is our V rate. When we checked our heart rate on our EKGs, we're measuring from QRS to QRS, which is ventricle squeeze to ventricle squeeze. Okay, so that's called the R to R. So technically we're going from the one ventricle squeezing to the next ventricle squeezing each so many times per minute. That's our V rate or heart rate. It's the exact same thing as heart rate. They just call it V rate sometimes. So then we have something called the A rate, the atrial rate. So on a regular EKG, that's at the rate at which the SA node fires. So the ventricles should squeeze in a regular cadence, but that means the SA node should as well. So on a regular EKG, we're measuring from P wave to P wave instead of QRS to QRS. Now they should be exactly the same for a normal EKG because everything should be spaced out correctly. We start getting into some of the arrhythmias, and then that A rate is going to be different than the V rate. Okay? So isn't that the same thing? I mean, it kind of is, but technically yes. So in cases of normal sinus rhythm, that A rate and V rate should be the same. But in other arrhythmias, as we're going to learn sooner or later, this is not the case, and it's one way to identify that there are arrhythmias. Okay? So let's take a look at an example here. So my face is probably in the way. We can see it pretty good. So let's find the V rate. So again, we're going to use this one that falls right on the line perfectly, and I can do the 300 method quite quickly. 300, 150, 175. I'm going to say this is probably like 80. We'll say it's 80. And then if I do the same with a P wave, I find a P wave that falls on a line. Here's one right here. And I go 300, 150, 175, and it's about 80. So did you see how I did that? I started with the P wave, this spike on the P wave right in the middle of this line, and I'm going to count the same way, down each box. 300, 150, 175, and here's the 80. So it's about the same. So down here we have an arrhythmia for AFib. This is called atrial fibrillation or AFib. You've probably heard of it. It's the most common arrhythmia I think there is out there. There is a controlled AFib as long as your heart rate stays under 100, and it does this weird little thing. It's okay as long as your heart's not doing jumpy things out of your chest and everything, right? So the A rate down here, let's do the V rate first. We can see very easily and quickly that this is not evenly spaced apart, correct? Not evenly spaced apart. So we know that this is when we're going to have to add up the QRSs and multiply, right? This is not a full 10-second strip, I can tell you already. It's 1, 2, 3, 4, 5, 6 second strip because 5 of these, remember 5 of these is 1 second, 2 seconds, 3 seconds, So 1, 2, 3, 4, 5, 6 seconds. So if I have a 6-second strip versus a 10-second strip, I will still count the QRSs, but now I'm going to multiply times 10 because 6 seconds, 1, 2, 3, 4, 5, 6 times 10 is 60. If you didn't get that, rewind it. Okay. Basically, it's a whole minute, so it's got to be 60 seconds, right? So I'm going to count these. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 times 10, because this is only a 6-second strip, gives me 100. So this is 100 beats per minute. So it's right on the cusp of being tacky, correct? So when we did the A rate up here, we were looking for P waves, and we're measuring P to P. Down here with atrial fibrillation, notice there are no definitive P waves or T waves. It's just a bunch of wiggles. These wiggles are really difficult to understand. This is the fibrillation waves. They're called F waves. Instead, they have F waves instead of P waves. No T waves. Occasionally a T wave will come through. So what we're going to do is literally measure the distance between the wiggles. Okay, let me show you what you mean. These down here are a little easier for me to... These are very wiggly here, small wiggles. I'm going to try to find ones that make more sense. So here's a bump right here on a line, and the next one over is 300, and there's the next bump. So this literally from one bump to the next bump is 300 beats per minute. So the A rate down here is 300 beats per minute. I'm going to say it again, okay? Or you can rewind if you need to. I'm going to say it again. So the A rate is usually the P to P, but since we don't have P waves, we have only F waves. Then we're going to measure from one wiggle to the next. And I just happen to find this wiggle right here on the line over to the next wiggle on the line, and that's at least 300 beats per minute. Up here, we'd measure P wave to P wave. Here's a P wave on the line, 300, 150, 175. There's my next P wave. So I'm going P to P. Down here, I'm just going wiggle to wiggle. They're super close. Okay, hopefully you got that. If not, we'll discuss it in class in person, and we'll do a little review when I see you next time. All right, or you can always rewind. Okay, so let's revisit the P to R interval. So the normal P to R interval is that 0.12 to 0.20 seconds, or it's 3 to 5 little tiny boxes. So 5 boxes is going to be 20 seconds. P to R interval represents the time between the start of the atrial depolarization and the ventricular depolarization. So it's all the way from here to here. So remember that the P to R was not actually to the R. I don't know why they don't call it P to Q, but it's at the beginning of the P wave over to the Q. The R is here, but it doesn't want you to go that far. You're only going to the Q. It's actually P to Q, but they call it P to R. Okay? I know it's stupid. That's ridiculous. I always get confused with it too, but I know that I go to the Q. So the P to R interval below measures 9 little squares. So if we see this is the P all the way to the R, and we get this is 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 little boxes times 0.04 is 0.36. Okay? Our normal P to R obviously is just 12 to 20, and this is 0.36, so this is much longer than it should be. And this would determine a first-degree heart block. These are usually benign, and we'll learn more about them later. But notice that the P to R is long, and you can tell the P wave is quite far away from the QRS. It's closer to the T wave than it is to the QRS. So one way to eyeball whether it's a first-degree heart block or an elongated P to R interval. Okay. All right, so a P to R interval, let me move my face again. I'm going to move it over here. Okay, so this P to R interval on here measures about 2.5 little squares, which is only 0.1 seconds. Okay, so there are short P to R intervals as well. So sometimes this means there's a junctional rhythm happening. Again, another type of arrhythmia we'll learn about more later. But note that the P to R intervals can be short as well, as long as they are less than 0.12. And then this one down here shows this very specific type that has, this one has a delta wave. And notice that the P to R is literally right there. It's 2 little tiny boxes, which is only 0.08 because 2 times 0.04 is 0.08 seconds. This delta wave, if you notice, the QRS is supposed to be much narrower, and it's got this little slur here, if you will. It's just kind of like zoop up, right? So it's kind of, this is the delta wave. It kind of lets us know something that they possibly have Wolff-Parkinson's White syndrome, it's called. Okay, that is another arrhythmia we'll learn about later. But just know that there are differences between the normal P to R, long P to R, and short P to R. And if they're not in that normal range, it typically means something, some sort of arrhythmia. Okay. All right, let's keep going. Okay, so our QT intervals, that is the largest interval we'll have, and then normal is 3.36 to 0.44, or basically 9 to 11 little boxes, if you count the little tiny boxes, okay? And it's measuring the time it takes for the full cycle of depolarization and repolarization from the ventricles. So we're leaving the atria depolarization out, and we're just counting the depolarization and repolarization of just the ventricles. We're going to leave the P wave out of this. So we're going to start right at the beginning of the Q wave and go all the way to the end of the T. Okay, it should be somewhere between 9 and 11 little boxes. This one you can usually eyeball a little bit too. If it's really far away, that T wave is super far away, then we hopefully know we have an elongated QT. So in a short QT interval, which is just the opposite of long QT, the heart obviously takes less time to recharge, and causes, like some causes are typically hypercalcemia, so high calcium levels can actually cause this. And you'll see the T wave like really super close to the QRS, normal, and then a long QT is going to be a lot longer. So here's the long QT. Notice the T wave is much further away from the QRS than this one. Okay. So the long QT is worse than short QT. It can actually lead to, it takes much longer to repolarize, so those ventricles aren't ready to squeeze like when they should sometimes. So it actually, if it gets too long, it can lead to cardiac arrest. We really keep a close eye on long QT. Short QT, it's usually just some sort of electrolyte imbalance like calcium, and they can usually fix that pretty quickly. But long QT is something we want to keep an eye on regularly, and it can lead to cardiac arrest, unfortunately, if it's not taken care of. Okay, so what exactly is QTC? So on your EKGs themselves, oops, excuse me, I went the wrong way. Let me go back. So QTC is, that C stands for either corrected or calculated. So we have a QT interval. That is the exact measurement between the beginning of the Q wave to the end of the T wave. A QTC is, they use a formula called the Bazette's formula. And it's a big mathematical problem that I don't like to do. But the machines do it for us. We're very fortunate the EKG machine will do it for us, okay? So the QTC is measured by taking the square root of the R to R interval in seconds. So it's just another way to look at it. So typically when they look at the QT and the QTC, they look to see that both of them are kind of somewhere in the range of where it's supposed to be, 0.36 to 0.44. Sometimes you'll have one that's a little higher than the other. A lot of the doctors rely on the QTC more than the QT, just because it's more accurate to them in their eyes, that it's more accurate based on the R to R interval. But it can be caused by lots of different things. Sometimes it's just congenital. They're born that way. If it's acquired, meaning you kind of do it to yourself, usually if something is acquired, it's a lifestyle choice that you've made, unfortunately. But it can include ischemia, any electrolyte balances, hypokalemia, hypocalcemia, hypomagnesia, and a variety of drug overdoses. So the long QTC I see in the hospital most often is those drug overdoses. And because they have this long QT, it does raise the risk of sudden cardiac arrest quite significantly. We are doing EKGs on these patients about every 4 hours just to make sure it hasn't changed or gotten into a really critical or lethal range for that QTC. So yeah, I see these patients, unfortunately, the overdose patients, very often because we're just checking their QT, making sure that they're going to stay alive, that their heart can handle it. A lot of the medications that they use as well can cause a long QT. So you would think a medication that's supposed to help you wouldn't cause other issues, but occasionally that does happen. So they'll monitor those patients as well. About every 4 hours, we'll do their EKG just to measure their QT and QTC. Okay, so here's some medications. Move my face again. So medications that can cause a long QT. So amiodarone is an antiarrhythmic drug. Notice they're all antiarrhythmic drugs actually. Sotalol I think I see the most often. It's a drug given to patients that have persistent something called VTAC, or high tachycardic rates, with weakness and other things, or they pass out and all that stuff. Dofetilide is for, a lot of times, for AFib and aflutter, and quinidine, I see that often too. They're all to fight arrhythmias, to keep their heart rate down and to make sure that their heart stays acting appropriately so that they can live their everyday life. But unfortunately, they can cause long QT in some patients. So the one drug that's supposed to help them with their arrhythmia can in turn give you something else that you don't want, which is long QT. So once these patients are put on a new antiarrhythmia drug like one of these, in the hospital, they are monitored for a few days. They're monitored by the doctor to make sure all their vitals are staying persistent and they feel well. They're not dizzy from it. They're not nauseous. They're not any of those things. And we're checking their QT. So I see these patients. I get to know them very well. I get to see them every 4 hours. Yeah. All right. So what meds do long QT patients take? So if you have acquired it, or you were born with it, most of the time they are commonly prescribed something called a beta blocker. So remember what beta did? We talked about beta. Beta was one of those autonomic sympathetic receptors that increases the heart rate. Okay, that includes how quickly it contracts, automatically, and the conductivity speeds up. So it's doing all of those things. It increases them. That's our fight or flight, our beta 1. So if we block beta 1, so if we block that primary sympathetic receptor, right, the heart rate, the automaticity, the conductivity will slow down automatically. Okay, I have a picture on the next slide that shows exactly how that does it, kind of like microscopically, of course, inside your body. It's doing that at the cellular level. Cellular level, yes, it's pretty cool. So beta 1 sometimes gets excited when it shouldn't. And if it stays that way regularly, just by you standing up and it shoots up more than it should, then we can give them this medication, a beta blocker, that will keep it down, just so that when they stand up and walk around, they're not in the 150s and 160s, going into some weird arrhythmia, and putting unnecessary stress on the heart. So this is kind of what beta does here. So obviously, this is your nerve ending, the receptor sites, and this is where beta would meet the nerve endings. But when we take a beta blocker, say these little squares of the beta blocker, they go into the receptors, so now beta can't talk. So your nerve ending can't talk to beta, so your heart rate stays down. It can be a little contraindication when we're trying to do like a stress test or something, get their heart rate up and they're on a beta blocker, because that's meant to keep their heart rate down. So kind of a contraindication, and we'll get to that too. All right, so that QRS complex represents, again, that ventricular depolarization as the Purkinje fibers are squeezing. And that normal QRS should be somewhere between 0.08 and 0.12 seconds, or basically 2 to 3 little tiny boxes wide. A QRS that's longer than 12 seconds is considered abnormal. A wide QRS like this one here in the picture, to me, looks out of place. I call them aliens. They look like they don't belong. This is technically, you'll see this is called a PVC. And again, we'll learn those. They're premature ventricular contractions. You'll see these also in right bundle branches and left bundle branches. That's what LBBB and RBB stand for. So just to kind of give you an idea, one thing to look for, you'll see that these big wide QRSs are out of place. They don't belong there. A narrow QRS right here just means that those ventricles are squeezing faster than they need to, or they're ahead of the game, if you will. When we have a arrhythmia called SVT, it's a very fast heart rate. When your heart rate is increased very fast, up to like 170, 180, 200 beats per minute, that QRS does narrow a bit because it's having to repolarize very quickly to keep it going that fast. We also see this in infants and little children. Basically, when they're born, their hearts are brand new. So they have big, strong hearts, and they can pump fast and need to pump fast because they're smaller than ours. A smaller heart beats faster than a larger heart. So they need it to be narrow, just so they can repolarize a little quicker to keep it going the heart rate it needs to be at. All right, so we are going to, this is a good place to pause if you need to take a break. So go ahead and pause if you need to, and we'll start back up again in a few minutes. If not, we're going to keep rocking and rolling. So pause, bye if you're taking a second. If not, I'm going to roll. Okay, so 12 lead EKG. So we're learning exactly the lead placement for a 12 lead EKG. And here's just a preview of what that looks like. I'm not sure what just happened. I think it clicked on a link, which I don't know why it did that. So let's start over again. I'm not sure what happened. Here we go. Okay, on to the next slide. So here on your worksheet that you have, your note sheet, you're going to write down the correct anatomical placement for each of these leads. So our first 6 are called V1, V2, V3, V4, V5, V1 through 6. That V stands for ventricular, so it's like a ventricular squeezing or heartbeat, right? So that's all that stands for. And we have 6 of them that get placed on our chest. And these are the correct anatomical placements. All right, so looking over here on our skeleton dude here, Mr. Bones, if you will, we're going to look at something called the 4th intercostal space just right of the sternal border. So when we read that, you're going to think about what that means. So intercostal spaces, if you remember from anatomy, is literally the space between the ribs. So here's a space here, 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 and here, right? Spaces between the ribs. So we're going to count down the 4th intercostal space from the top. Here's the top. 1, 2, 3, 4. And this one's going to go just right of the sternal border. Remember, it is the patient's right. So my right's over here, which is the patient's right, okay? You're looking at me, and you're looking at, this would be my chest. So this is the patient's right. It's going to be opposite of yours. Think of the patient, if you turned around, and you're facing them, this is their right side. So my first sticker would go right here. I'm wondering if I can actually do that. I think I can. This is going to be exciting. We're going to give it a try. Again. 1, 2, 3, 4. All right, so there goes my first one. That is V1. Okay, so that is the 4th intercostal space just right of the sternum border. Here's my sternum. It's to the right, and it's 1, 2, 3, 4th down. V2 is placed in the exact same spot on the other side. So 1, 2, 3, 4, and it's going to go on the left side of the sternum border. Now notice that V3 is very scientific, somewhere between V2 and V4. So we got to place V4 first and come back and we'll place V3. Once you get used to placing them, you kind of get an idea where it goes. You can kind of eyeball where it goes already. But let's take a look at V4. So V4 is on the 5th intercostal space. So we've now moved down a space. Here's this is 4th intercostal, this is 5th intercostal. Okay? And it's mid-clavicular. So the clavicle up here, if we were to take the middle of the clavicle right here and draw an imaginary line down to here, on the 5th intercostal space where those two intercept is going to be V4. And now I can go play it back and place V3, which is going to be somewhere between the two. So I'm just going to put it right here. Now V5 and V6 have to do with the axillary line. Axillary, if you recall from, again, from MedTerm or from anatomy, axillary refers to your armpit, just a fancy word for your armpit. And anterior meant the front, and mid means the middle. So this one's staying on that 5th intercostal space, right? Anterior axillary is the front of the armpit. So it's going to go right here. And the 5th intercostal space is going to go mid-axillary, so it's going to go right here, kind of in the armpit, right there. So here's V1, 2, 3, 4, 5, and 6 on our little dude. I'm so excited that worked. That was fun. All right, make sure you've got all this written down, and you have a picture on your notes sheet as well that has a chest on it with, you know, the intercostal spaces and the ribs and everything. So if you want to pause it and make sure that you've got it all written down correctly and drawn the little circles on there, this would be a good place to pause as well. I'm going to take a drink. All right, if you still need some more time, keep pausing. I'm going to shut my little pen off clear it off. And we're going to go back. Here we go. Okay, so that was the first 6, and now these are our limb leads. So we have 4 other ones that go on our body, right? So this is our 12 lead EKG. We put 6 on the chest, and we have 4 limbs. So how many stickers is that? You're right, it's only 10. So how the heck is this a 12 lead EKG when there's only 10 stickers? We'll get to that, okay? It's a little confusing at first. But notice that RA just stands for the right arm, and we typically go for the wrists. LA stands for the left arm, typically go for the wrist. We have RL, which is the right leg, and LL, which is the left leg. And again, we typically go for the ankles. Now, take special note that the right leg is considered ground. Okay, so our right leg is ground. We don't use this one for any of our determining our 12 leads on the EKG. It's just ground. Anytime you have an electrical conduction flowing, just like when you jumpstart your car, you have to ground one of the wires. We're grounding one of the wires on our body, and the right leg is the ground. Think about it, it's the furthest away from our heart too. So it's not really anywhere near our heart. Our heart is up here on the left. It's the furthest part away. Now, a limb lead technically can be placed anywhere up and down the arms and legs as long as they match on either side. Because you're like, wait a minute, Slattery, what if they only have a left arm and not a right arm? Why do they only have one arm? That doesn't mean you put it on one arm and not the other. You can just move it up to the shoulders. So we have a right arm here and a left arm, and same with the legs. If they have an amputation, you have a big wound down there, it's wrapped up with bandages or a rash or some sort of skin lesion, whatever, and you can't put stickers on it, you can move it up to their thighs. And even worse, if they don't have legs at all, then not worse, but another option, if they don't have legs that are viable at all, then you can actually move them up to their torso, right on their belly. We're going to get to that in a minute. So RA just stands for right arm, LA is left arm, RL is right leg, and LL is left leg. And you'll see when we look at the wires and the wire placement, and we'll do that in person next class, that you'll see that they are color-coded. I'll teach you those as well. And they have the little abbreviations on them, RA, LA, RL, and LL, just like V1 through 6 as well. All right, so why would we modify our placement? So a modified lead placement means we're taking them off the limbs. I kind of gave you some hints there before, but think in your brain, like, why would I modify my limb placement? Why would I take it off their limbs? Like, take it off the arms and legs and put it someplace else. On the torso is where it's going to go. I had mentioned already, hopefully you're thinking already in your brain, I had mentioned already that if they have wounds, if they're missing a limb, if they have an injury, a burn, all those things are good reasons to do this. Another reason to modify the lead placement is because when we do a stress test on a treadmill, think about having wires on your ankles and legs. Number one is a tripping hazard, right? And number two, you're going to have whole kinds of something called artifact. It's going to really mess with the picture of your EKG. So we're going to move it off the arms and legs and into the torso as much as we can. So we're moving just the limbs. V1 through 6 stay the same. So RA, so normally it'd be somewhere on the arm, is going to move up just underneath the right clavicle. Left arm is going to go right under the left clavicle. Now right leg and left leg are going to go on the torso here. On the belly, notice it's typically kind of on either side of the belly button. And notice it's nowhere near the diaphragm. So your diaphragm's right here underneath the ribs, correct? It's nowhere near the diaphragm. If we put our stickers near the diaphragm, then our EKG that's supposed to be nice and flat, that isoelectric line nice and flat across the bottom, may not be flat. It may mimic our breath patterns and go wavy like this. And then it's really difficult to read. So we're going to make sure that we have it away from the diaphragm. All right, let's keep going. So here's my shortcuts. I always have shortcuts. Slattery's got some shortcuts for you, okay? So instead of, I want you to think about, okay, now I have to go put these stickers on a patient, okay? I have to put these stickers on my friends in class, and I have to put them on a patient of someone I absolutely don't know, right? Yeah. Do you actually like put your hands on there and just start feeling around down the intercostal spaces? 1, 2, 3, 4, 5. That would just be weird, right? It's just weird to be able to do that. Why are you feeling the chest all over? The patient will look at you very strange if you do, by the way. So just know that we have a couple of landmarks on our body that help us with that. So V1 and V2 are placed technically just above the nipple line on either side of the sternum. So if our imaginary nipple line runs across here, then V1 and 2 are just above that on either side of the sternum. Okay. So for us ladies, it's just above the nipple line, of course, right here on either side of the sternum. So your fifth intercostal space is kind of shaped like a Nike swoosh. And I'll show you this in person as well in class. But if you look at the skeleton, if you ever looked at the skeleton, the ribs do not go straight across. They go in this swooshy thing, right? In a Nike swoosh. So follow that U shape. Once you place V1 and 2 and you start to do this through 6, it should make this Nike swoosh U shape up into the armpit. Okay? And for males, your fifth intercostal space is right under the breast tissue. It's that natural indentation under a male. And that's your fifth intercostal space. Okay, it's very easily spotted. On mannequins, you would see that indentation also under the breast tissue on the male mannequins. For us females, it's literally where our bra sits. So that bra line that we have, that is our fifth intercostal space. Okay, so you don't have to feel around on anybody. Just know those landmarks and kind of work your way through it that way. Okay? And then the next question usually comes is like, what if the breast tissue is in the way of my fifth intercostal space? You're going to have those that happen. There will be females that have breast tissue in the way of your fifth intercostal space. So we're obviously going to be professional, and we're going to very carefully and eloquently just use the back of your hand to push the breast tissue up so you can put your stickers. Okay? In class, obviously, females will be wearing sports bras, and that's what I would recommend anyway. Wearing sports bras, and we don't have to usually move anything out of the way. If you're not comfortable doing that, you can ask the female to actually move it for you. Okay? Do you mind moving your breast tissue up for me? They have no problem with it usually. Okay? The best way, though, to not be invasive and make them feel uncomfortable is just use the back of your hand and lift. We'll practice in class. We'll kind of practice in class. We'll go over it more in class. Don't fret. Okay. All right, so more shortcuts. Since V4 is placed mid-clavicular, do exactly that. Find the middle of the clavicle, draw down, and where it intersects that fifth intercostal space. It's usually right under the left nipple, believe it or not, down in that little indentation. Once it's placed, go back and place V3. As long as you stay in that Nike swoosh with 5 and 6, you're going to follow that Nike swoosh up into the armpit. V6 should technically be in the armpit. And avoid that diaphragm whenever, so that you don't get the breath signals or weird wavy things on the EKG. We get a nice flat isoelectric line to be able to read. Once it's wiggly like that, the doctors really can't read it. It's hard to, take measurements of intervals, P to R's and all that stuff if it's too wavy. All right, so hopefully we are there. And again, if you need to pause, you need to catch up, go ahead and do so. All right, so lead direction. So how come, like I said earlier, how come we only have 10 stickers and it's called a 12 lead EKG? Makes no sense, right? It was very confusing to me first when I first learned this. I was like, why are there only 10 stickers? You said 12 leads. I was almost afraid to ask. So V1 through 6 read the electrical conduction of the heart exactly where they're placed on the chest. So we get exactly here on our chest, okay? Leads 1, 2, 3, AVR, AVL, and AVF, okay? On our EKG itself, read the electrical conduction that flows between the 4 limb leads. But we only use 3, remember? Because we don't use right leg, it's ground. So we're using right arm, and left leg. And those they send signals to each other in different angles, in 6 different angles. So we have 6 of our leads come from V1 through 6, and 6 of our leads come through right leg. No, I'm not right leg. Right arm, left leg, sending signals to each other in 6 different angles. So that ends up being 12 altogether. Okay, so we're going to check them out on the next slides here. All right, so on your paper, I actually have mine with me too, so I can do this with you and make sure that you have it written down correctly. I'm getting to it now. Almost now. Where's my thing? So you should have your picture of, there we go. of your torsos, right? And I have my camera, I'm going to slide over in here. So on your torsos, you have 4 torsos. Draw 4 circles, R-A-L-A, R-L, and L-L, okay? I'm going to pull my camera over so that we can look at it together. It was there a second. There we go. Here it is. All right, I'm just going to make it bigger so you can see it better. And that's in the way. All right, so on your little mannequin torsos here, or I guess they're not mannequins, on your peoples, draw the 4 circles on each. These are gonna represent our modified limb leads. Okay, 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. And 1, 2, 3, 4. So you're like, aren't there 6? But there'll be 6 here in a moment. So these are our limb lead ones, okay? And you can see that I have more shortcuts down here. So remember, V1 through 6 pick up exactly where we placed them. So this is my right arm over here, my left arm, my right leg, and my left leg. Remember, it's the patient's right and the patient's left. This is ground. We're not even going to use this one. So we're going to use these 3, okay? All right. So I'm going to just move on to the next slide and we'll do it together. So hold, please. Okay. All right, so these are your limb leads V1, 2, and 3. These are Roman numerals, and on the EKG, when we look at an EKG, you'll see that it goes 1, 2, 3. All the way to the left, those are the first leads that we see. Okay, leads 1, 2, and 3. So on our pictures, we're going to do exactly this. So lead 1 sends a signal from the right arm over to the left arm. So you're going to draw an arrow from the right arm to the left arm and label it Roman numeral 1. Lead 2, okay, lead 2 goes from the right arm to the left leg. And this is, label it, so draw the arrow from the right arm to the left leg and label that Roman numeral 2. And lead 3, Roman numeral 3, goes from the left arm to the left leg. So 1 goes across this way, 2 goes here, and 3 goes here. So that means that the right arm is talking to the left arm in lead 1. In lead 2, the right arm is talking to the left leg, and in lead 3, the left arm is talking to the left leg. It is significant. You definitely need to know these, okay? All right, so let me pull up my camera again, and I'm going to draw them on mine so you can see how I did that. So here is arrow 1 for lead 1. That's lead 1. It's hard to read that, isn't it? That's lead 1, my arrow going this way. Lead 2, not to the right leg, to the left leg. Lead 2. I'm going to write it over here just so it's easier to see. That's lead 2. And lead 3 is going to go from the left arm to the left leg. It might help if you have some colored markers or something, or a colored pen like I do. So that's lead 3, 1, 2, 3, Roman numeral 3. Lead 1 from the right arm to the left arm, lead 2 from the right arm to the left leg, lead 3 from the left arm to the left leg. That's leads 1, 2, and 3. Okay? All right, I'm going to put this down. You can see that one again real quick. Make sure you have that written down. If you don't, pause it and get it completed now. Okay, let's move on to the augmented ones. So we have AVR, AVL, and AVF. This one is AVF. A stands for augmented. V stands for ventricular. F in this case stands for your foot. So it's an augmented lead that lands at your foot. Since we don't use the right leg, it's going to land at the left leg. It's going to land at the left foot. Okay? So the augmented leads use all 3 of our leads. There's 2 of them that talk to each other first, and then they send a signal to the 3rd one. And since this is AVF, the only three that we use are the two arms and the left leg. We don't use right leg, it's the ground. So the right arm talks to the left arm, they meet in the middle, and they send a signal to the left leg. Right arm talks to left arm, meet in the middle, sends a signal to the left leg. AVF, augmented, meaning we all use all three of them. V stands for ventricular, F stands for foot. Go ahead and write that down. I'm going to go back one because I forgot to mention to you. This one right here, our lead 1, 2, and 3, look what it forms. A triangle. You got it. And what was Ian Thoven's triangle? 1 plus 3 equals 2. What? This is Ian Thoven's triangle. So that means the size of this one plus the size of this one should be the size of this one because it's the long one. It's a squared plus b squared equals c squared. Ian Thoven's triangle. Mind blown, right? Crazy. I forgot to say that. I was excited to go back and tell you. Okay, let's get on this one. So AVF, let me write this. I'll put my camera up so you can see how I read it on mine. So I'm going to use this guy over here. This is going to be my A, and it's written with a small a, capital V, capital F. AVF. Augmented ventricular foot. It's going to the left foot. This is my left foot here. Left leg, right arm, left arm. And since it's augmented, I have to use all three leads. So this one is going to talk to this one in the middle. This one's going to talk to this one. They meet in the middle and they head down to the left leg, just like that. So right arm and left arm meet in the middle and send a signal to the left leg. We don't use right leg, it's ground. So if it's F foot, it's got to be the left foot because it's the only one we got. Excellent. Hope you got that down. If not, pause and do it and catch up. Okay, let's move on to AVL. So AVL, A, augmented, V, ventricular, L stands for left arm. Okay, we have a left arm. And since we only use three leads, our Ian Thoven triangle leads, we don't use right leg, we have to end at the left arm. So that means the right arm and the left leg send a signal down the middle, and then that goes to the left arm. So they talk to each other first, send a signal to the left arm. Right? We're only using three arms. We have two arms. We're only using three leads, not the right leg, that is ground. So therefore, right arm and left leg are going to talk to each other and send it to the left arm because this is AVL, and L stands for left arm. Yeah, it's as simple as this. Okay. These are my cheats, by the way. No one taught me like this. I was so confused when I first did this, and I started thinking out the cheats and everything. All right, let's do our AVL. A, small l, capital V, capital L. AVL, augmented ventricular left. Since it's left, we're going to land at the left arm. Remember, this is the left arm. This is the right arm, right leg, left leg. And since we're landing here, we do not use that one. These two are the two that have to talk to each other first because we're augmenting it and sending it over to the left arm. So right arm talks to left leg. They send a signal. They meet in the middle, send a signal to the left arm. Are you getting it? There's one more to go. AVR. Okay. So AVR, R stands for right arm. This is so easy, right? So easy. I bet you can guess how this goes. Well, it's showing up on the screen too, but I'm giving you the benefit of the doubt, and I think you're all amazing. So you should know how this goes. All right, so this is AVR, right? Notice that R is going to stand for right arm. So we're going to land on the right arm. And since we only use these three leads, the other two talk to each other first. Left arm and left leg talk to each other first, and then send a signal to the right arm because it's AVR. Notice that AVR is going away from the heart, away from the apex. This is going to be significant on the EKG later. So notice that when we go away from the apex, the EKG QRS is going to look a little different. Okay? Just keep that in your brain. All right, let's do it on my paper. I'll get my camera out. And AVR coming your way. AVR, it is a lowercase a, capital V, capital R. We're landing here on the right arm because R stands for right arm. Okay? So that means these two have to talk to each other first. So this goes to here, they meet in the middle, and then they send a signal to the right arm. Again, notice it's going away from the apex, right? All right, that's our pictures. You got them? You can always stop, rewind, do it again. We are going to touch base on this again in class, in person. Our first part of class is always going to be a quick little review. So we'll go over this again in class just to make sure you got it. All right, and this is just a way to look at them all. Six of the 12 EKG tracings, the directions in which they go. Here are my shortcuts. So my cheats or shortcuts, whatever you want to call them, so you can fill in this chart. It's all stuff that I told you while I was showing you the pictures. But lead 1 from RA to LA, lead 1 only contains one L. And the flow only has one L, right arm to left arm. Lead 1. So looking at the Roman numeral 1 can look like an L. Lead 2 has 2 L's. Right arm to left leg. And lead 3 has 3 L's, left arm to left leg. If you want to, just use some sort of cheat to remember which direction they go. So lead 1 has, if we think of this as an L, it has 1 L, right arm to left leg. And 2 has 2 L's, right arm to left leg. This is left arm, I'm sorry. Lead 3 has 3 L's, left arm to left leg. So 1, 2, 3. Just a way to remember. Okay, quick way to reference. Go wait, if the Roman numerals are actually L's, how many L's does it have? And knowing, of course, we don't use the right leg, so that would never fall into this. Okay, pause if you haven't quite finished. I'm going to move to the next slide. So here's your augmented lead shortcuts. I kind of went through these already. R stands for right or right arm, and since we don't use the right leg, the only other two leads must meet in the middle, obviously, for AVR. AVL, L stands for left or left arm, and since we don't use the right leg, the only other two leads must meet in the middle, like I said before. And then for AVF, that F stands for foot, and it has to be the left foot because we don't use the right foot, and the only other two leads that we have must meet in the middle first, and then send an augmented signal to the foot. Yeah, so I've said all this before. You've got the pictures. I helped you draw them. I went through the pictures 2 or 3 times, and now here's your little shortcuts to help you remember where they go and which direction they're headed. If you remember you don't use the right leg, it should all become easy. And that the R stands for right arm, the L stands for left arm, and the F stands for left foot. Simple. You only got 3 to work with. So as long as you know where it's supposed to end, you can figure it out really easily. Okay. This is where we're going to take a break. There is going to be a second video. So I'm going to end my video here, and there will be a part 2 to our lesson 2. And it's on one specific topic. It just takes a little bit of time to explain. So I want to make sure I have enough time to do that. And you've had some break and rest and stretch and all that stuff. So I'll see you next time.